Thank you very much. So before to start, let me give you some context for you to understand why we do the thing that we do. So we belong to this Foundation Progress and Health, which is actually is not a hospital foundation, but it's a foundation of the health system. So in that way, we can interact with different hospitals, and they see us as part of them. They don't see as the foundation of the other competitor hospital that goes for their data, right? So in that way, we start to do more or less all these things. So we have a course specifically designed directed to our clinician, and we teach that the what we call the data cycle, and this is like the water cycle that rains and then goes to the sea and evaporates, etc., etc. So that's the idea. So essentially, what we do is to use knowledge we extract information from our patient. It could be genetics information, genomics information, but it could be any other type of information. And using this knowledge, we do diagnosis, we do recommendation of treatment, etc., etc. So where this knowledge comes from? This knowledge typically, traditionally, comes from research. So we specifically go for a number of patients and do some measurements and try to correlate phenotypes with this information. The case of, for example, of biomarkers is quite obvious. So we correlate some biomarker with some response to treatment or whatever, and this is what we use. Point is that this information traditionally was generated on purpose for specific experiments or research. But the point is that we are generating data from our patients anytime that we do any measurement. But typically, this information was in the past was made on paper, so it was completely unuseful, or it was contained in local silos, which at the end is unuseful. But now with the digitalization of the health system, we can store this information and use directly this information to get new knowledge. Instead of generating information or the data for on purpose, we can use that. Is what we call real world data, and this is what we call secondary use. Think that when we extract this data from our patients, the purpose is for patient management. It's not for research, it's for patient management. And we can use that in the future for secondary use. And this is perfectly legal without the context of GDPR, right? So let me show you or explain you how that works in our region. So we are in Andalusia, south of Spain, and this is a big region. Actually, this is the third region in Europe. It's behind Paris, I think, is the biggest, and the second one is in Italy. I don't remember which one. And this is 8.5 million inhabitants, which is like Switzerland or like Austria, and like it's bigger than half of the countries in the European community. So this ecosystem of digitalization dumps or the data on the population database, where the data are all integrated and structured, because we always have problems to extract structured data from the electronic health record, but in database they are structured. These are some figures. So we are talking about 15 million patients in the information for 15 million patients. The current number of users is 9.4 million. I mentioned that we were 8.5, so we have almost 1 million of population that are people from other European countries that live in the coast, etc., or people who pass through the community, etc. 1 million population, which is a floating population. We have 752 million of diagnoses in database. 3 million of functional assessments, cognitive assessment, vaccination, diagnosis. We have 123 million of diagnostic tests. So there is all the data of the diagnosis test. A blood test with all the items are all then stored there. Many other constants like weight, height, BMA, blood pressure, so that's 61 million. And we have also this 36,000 COVID genomes, and we are starting to collect genomic data, human genomic data. But we use first the COVID data because it's easier to organize the collection, and we are essentially divided. We have divided in East and West Andalusia, and we were collecting, sequencing into hubs and collecting all the data, and we will collect data of patients, also genomic data of patients in the future. So this data source, this BPS, the population database that contains 15 million patients, is what we call real-world data. So keep in mind that this data is not obtained in the context of a clinical trial, for example. So you don't have in many cases in an explicit form the information that you need, right? But you can extract in some cases. For example, we have a very nice collaboration with some psychiatrists and the hospital, and they say, okay, if the schizophrenic goes well, but what the schizophrenic goes well means. So how we don't have a clinician specifically taking care of saying, okay, it goes well, it's not going well. I say, okay, going well means that it goes less than 5 times per year to the intensive care or to the emergency room. Okay, so you can quantify. So in some cases you don't have the explicitly the information, but you can implicitly obtain the information. And from other perspective, these data are even more interesting than clinical trials, because in clinical trial you have a sort of fictitious population. Here we have the real population, so the people get older, have other comorbidities, they take different drugs while they are taking the drug and you are interested on. So you have you compensate with a much bigger N, and with a real population you compensate the detail that you lose in a clinical trial. So we have legally the access to the data was due to a resolution in 2 years ago. Well, it was, I mean, there was another resolution before, but this is the new one. So essentially what you need is a data request document, a protocol in which you describe the study, an analysis of the impact on data protection. So what are you going to do with the data, and the approval of the ethics committee. So this is what we call the paradox of clinical research. What happened is that due to data protection, we have the data and the people who know what are the relevant questions that we can do on one side of this firewall, and you have the computation and people skilled in how to analyze data on their side. And this is, to me, this is an obsolete design, because this is due to the fact that only 10 years ago the hospital didn't produce data. So where was the point in having computation within the hospital if the hospital only produced paper? But now has changed completely the situation. So what happened is that if we follow the traditional way of doing things, in which we extract data from the health system, we are in a situation in which the health system is generating data, and this data is custodied in this secure environment, which is expensive. but this data is extracted. Then is analyzed outside, and in some cases, the product of this research is sold again to the health system. So the health system has to pay for this. So it's a situation a bit strange for the health system. Obviously, we have all the problems of the data protection risks, and well, I mean, I don't need to insist on that, but you know that there are obvious risks, or the identification of patients, and it can be done. And actually, when people say, okay, but we anonymize data, so you can anonymize data like we have seen in the previous talk, because these data are vital constant measurements, temperatures, etc., etc. You can identify a patient by that. But when you have clinical data, including when and where a patient was to the health system and what happened to him, etc., to her, this data can easily be re-identified. And anonymization is it's not possible in many cases, because or anonymization is something that we do specifically for a project, because in some cases they say, okay, you remove anything that can identify a patient, but in some cases you need some identification, or maybe some for example, physical location of patient, something that if you remove them you are degrading the information. So anonymization is something that we do specifically for any specific project. So what we have in mind is a transition to a system in which we have computation within the health system. So you don't need to extract the data from the health system, but this data should be accessible by data scientists. That's the idea. And actually, in that way, you make to the health system part of any benefit that can be extracted from this research, and you are making a more sustainable health system at the same time. So I'm giving you my view from the perspective of the health system. So the solution is for this computation what many people call trusted research environments. So we managed to set up one of these trusted research environment, and actually, well, I don't know in your country, but in Spain, it's not difficult to get money for machines, equipment, etc. It's very difficult to get money for people to manage this equipment, but equipment for some reason is relatively easy to get. So we make what they call an infrastructure, which is something that you can offer to people for doing, in that case, doing calculation inside. And the idea is instead of taking the traditional pathway of anonymizing the data, sending the data outside, obviously there is a procedure in between that we cannot avoid, which is passing through the ethical committee, getting an approval of the ethical committee, and making an evaluation of impact in data protection. But once this is approved, instead of doing that, we do that. So we analyze the data within the health system, and then we extract the data. Something which is interesting is that we don't anonymize data. We pseudonymize data, meaning that data can be re-identified. And some projects is quite interesting, because some projects we have to identify patients that have wrong or have not been diagnosed. And if we can identify them and we can propose a treatment for them, we need to be able of re-identifying the patients. You anonymize the data, you can find them, but you cannot link them, so they will be forever lost in the health system. But the idea is also when we are starting to play with this, to allow people from outside to manage the data from outside with a data processing contract. Well, this is one solution. other solution, and now we go to the now we go to the challenge, is patient simulation. So there are several strategies, but many of these strategies are based on knowledge, on the distribution of the variables within the patients, and you can generate patient using this knowledge. The problem with this is that if you use knowledge to generate patients, probably you are not learn much more. You are not generating new knowledge because you are generating the patient with the what do you already know, right? So the idea then is to use this different type of deep neural network to generate realistic patients with real data, and then this realistic patient can be exported. In that case, we will be in this situation. So the other type of generation is unrealistic, but this generation is more realistic. I don't know if you are familiar with generative adversarial networks. Have you seen these pictures that some of these people doesn't exist because they are synthetic people? Can you tell who is real and who is not real? Can you guess? You can find them in this web page. There are different web pages, and now with this generative stuff that galores or over internet, you can generate lots of them. Well, none of them is real, but they look very, very realistic. So this is only one strategy. So what this strategy does? So it used two type of networks. This is the reason for which they call adversarial networks. So you have a generator and you have a discriminator. So the generator start to generate random stuff, and the discriminator use real data to see, okay, this is not a face. Why? Because it has no eyes. Okay, then it gives feedback to the generator, and the generator start to put eyes. And you say, no, but this is still not a face because it has no ears. So it put ears. So after a competition that could be billions of rounds of competition, it ends up generating something that looks so close, so similar to a real face that cannot be distinguished. What is the difference with respect to the other strategies of generation of data? Because this data captures relationship between the variables even if you don't know that. So it can capture something that you don't know. And you can do research and you can find things in the synthetic data that you were not aware because you were not done this research before. So what we do is something very similar. We take the something that generates a random structured patient data, and we compare with real patient data, and we do all these rounds, and finally we get something which looks very much like a real patient. There are not only these GANs, this generative adversarial, but there are also variational autoencoders. There are other strategies, and actually we are starting to play with large language models. In a way of saying, okay, give me patients that are like this, and well, we are playing with this because we are not sure that it will work because sometimes these generative chats completely invent the responses and they are completely false. So we are playing a little bit, trying to see if we can using embeddings, using other strategies. But I mean, there are different strategies, and this is what we did essentially. We did this realistic simulation. We released the data, and we can offer validation of the methodologies. So you can predict something, we can validate in the real data. So in that case, for the first time, about 1 million of simulated diabetic patients are freely available. So they are not affected by GDPR because they don't belong to real patients. So you cannot identify any patient because they are not patients. So it could be a solution. So we want people use that massively in order to demonstrate that this is a strategy. We can, instead of fighting against problems derived from the regulation, protection, etc., we can generate this patient and we can make them publicly available. This is the last one. So the next talk, Carlos will explain a little bit more detail how we did this data set. So it includes not 1 million, but almost 1 million. Some of them were discarded for, and were generated from a cohort of almost 1 million real patients that we have in the health population. So, and what we suggest is to find different, try to predict different endpoints that, for example, retinopathies, kidney diseases, ischemic heart disease, or amputation. Or since CAMDA is an open-ended challenge, so you may want to predict other things or different things. I think that's all. Carlos will give you some detail, and these are more of the people involved, Carlos and Curro, who are working with me in Sevilla, Lola and Roman, who are the people from the database, and David, who was helping us from the IRI. So thank you very much, and Carlos will give you the continuation.
Hello, thanks for the talk. I have a question about this identification issue. So wouldn't it also be sufficient if you have a strict contract with the researcher that they do not apply technologies that would lead to the re-identification of patients?
Well, in principle, they cannot be re-identified because they're not real patients. You can identify.
You don't need the synthetic data, so you can then work on real data. So if you have a strict contract with the patients.
No, when we work with real data, what we make available is the synthetic data. We have the real data, but we have passed through all the stuff of the clinical committees, etc., and we have the data in a safe place. So.
No, but this is because the researcher would be, in principle, be able to re-identify the patients, right?
But yes, one of the things is, it's not only that; it's more part of the law. So you are not giving your consent, in principle, for anything. Because it's not. I have been discussing many times with people working with data. Say, I have my data open. Yeah, but your data are the temperatures in Europe in the last X year. So this nothing happened. But when it's your own data, you probably would like there to be there. There are many sensitive data. There are data of people with mental illnesses. There are people with. It's not something that could be around,
Okay, thanks.
And in principle, law doesn't allow this data to be open unless you give your consent. But if you want to have your data open, you can publish the data on the internet. You have the right of doing that. But if not, if the health system is taking your data to trade you, this data must be custodied by the health system and cannot be open.
Well, Joaquin, thank you very much for the talk. I think it's a very interesting thing looking forward, but I was worried a bit about data leakage. How can we make sure or evaluate that these models are not learning or replicating anything from the real patients and that the generated patients cannot used anyhow to re-identify patients later on?
That
Yes,
cannot be. Sorry, I didn't follow you. That if the patient can be identified from the fake data,
if
or
there's any evaluation pipeline or any prospect of evaluating that there's no replication of the real patients in the generated data.
well,
'Cause that could be
we
a danger.
did something about that, right? In principle, I mean, in principle, there is a risk. There is a risk. This is the reason for which we started with diabetic, and there are 1 million of patients. Probably you go to a less prevalent disease. One thing that the network can do is to learn by memory specific patient and reproduce specific patient. And in that case, it could be. We did some checks, but not very detailed because we don't think that at this level, level 1 million, it will be memorizing any patient and reproducing any patient.
Thank you.
But we didn't make very much checks on that.
Any other questions? If not,